Hey, how you doing?
Fine, thank you.
Everything okay?
Yeah, everything's fine.
Okay. Just let me know a minute.
Yeah,
before-
I'll text you before. Okay.
Greetings, everybody. Dr. Helmi, Mazen Abouad, and Dr. Bennett. We're starting in a few minutes. Hello, how you doing? We're starting momentarily.
Hi, Dr. Bennett. This is Mazen Abawad.
Is this Mazen?
Yes.
How you doing, Mazen?
Good,
Is your camera working, Mazen?
Yes. Do you want me to turn it on?
You don't need to. If you need to conserve bandwidth.
No, I'm actually at home, so I'm okay.
Yeah, if you could turn it on, that'd be nice. So that we can be ensured that not everyone is sleeping. There you go. Let's see here.
Okay.
There you go. How you doing?
Good, good.
Where are you from?
Actually, I live in the U.S.
Oh, okay.
I'm
Welcome.
from Jordan.
Have I met you before?
I don't probably. I mean, you look familiar, and the name is definitely very familiar.
Okay. Well, it's a pleasure to meet you. Where are you at in the States?
In Naples, Florida.
Oh my God, I'm in Miami Beach.
Oh, We're very close then.
Yeah. I used to
Which
go to
hospital you're at?
Fort Myers all the time.
Oh, which hospital you're at?
No, I'm just working on the internet. I'm not working at a hospital. Not anymore.
Okay.
I'm done with practice.
Oh, good for you. Good for you. Yeah.
I did more for medicine by retiring than by working.
Oh, that's good. I still work in Miami every now and then at Baptist Hospital.
Oh, cool. You work in the ER?
No. I'm a neurointerventional radiologist, actually.
Oh, cool. Great. Yeah. I'm televising a neuroradiology conference from Madrid.
Oh.
In January 11th and 12th.
Oh.
It'll be televised. You'll be able to see it. Let me show you the website.
Yeah.
Okay, let me share the screen. It's a great platform. You can learn how to use it. Okay, I'm sure. Oh, I better not. They're about to start their presentation. Okay. Okay, I got to get ready for game time.
Okay.
I'll talk to you after.
Absolutely.
Okay.
Thank you.
Assalamu alaikum, مساء الخير. Good evening. My name is Ibrahim Soyeh. I'm a neurosurgeon, and we are transmitting live from here, Amman, Jordan, at the Farah Medical Campus. This backdrop is the first Mercedes in Jordan and in Palestine by Tawfiq Gharour. This is Tawfiq Gharour and his son, and he brought the first Mercedes to this area of the world, 1922. And he used to bring these Mercedes in return for the Jaffa oranges, which are, as you know, world famous. This is 1966. This is late King Hussein receiving some of the female teachers visiting him in the palace. The presentation for today is the unusual case of a parafalcine parasagittal motor strip lesion. We'll discuss the clinical, radiological, operative, and pathological correlation. So you heard me talking about parafalcine, which is the forks, parasagittal. So let's look at this, the forks, the sagittal sinus, and the motor strip. This is the forks. The forks is a dural fold separating two hemispheres. Exactly in the midline, starts in the front here, and then goes back and joins the tentorium cerebelli. So it separates the right from the left. Tentorium cerebelli separates the infratentorial and supratentorial. So you have one infratentorial compartment, you have two supratentorial compartments. This tough fibrous membrane, as you see, it has longitudinal fibers and also oblique fibers. So it is really tough. So you need a knife to cut it. And in this, you'll find grooves with some blood vessels in it. The thing is this, that it is not sometimes complete. Sometimes you'll find some fenestrations in it, defects. And you have to be careful as a surgeon about this point. So the dura comes this way. This is coronal section. It divides into two parts, this part and this part. Also the dura in this area divides into two parts, this part and this part. These two parts join together to form the forks, and this cavity is the superior sagittal sinus. So the venous system of the brain is made of the sinuses and the veins. Sinuses, veins, superficial or deep. The posterior fossa veins are separate entities, so they are mentioned on their own. Dural sinuses, the superior sagittal sinus, the inferior sinus, straight sinus, sigmoid sinus, sphenoparietal sinus, cavernous sinus, superior petrosal sinus, and inferior petrosal sinus. Here they are. This is midline cross section. You can see the superior sagittal sinus, the inferior sagittal sinus, and the straight sinus. This is a 3D picture. The forks. On the top, there is the superior sagittal sinus, and inferiorly here is the inferior sagittal sinus. Inferior sagittal sinus will join the straight sinus. Superior sagittal sinus will go to confluence of sinuses. Straight sinus on this side, straight sinus on this side. Again here, superior sagittal sinus, inferior sagittal sinus, straight sinus, transverse sinus, sigmoid sinus. And here you'll see the internal cerebral veins and vein of Rosenthal. Superior sagittal sinus, and you can see the veins going into it in this direction. The blood flow is this way. So why are these veins going to the opposite direction? Because if they go this way, the minute you stand, you will lose all your blood and you will die. So the Creator God, the Lord, made this direction so that there are valves here that your blood return or venous return would be slowed down. Here's the inferior sagittal sinus. Here's the thalamostriate vein, septal vein, internal cerebral vein, joined by vein of Rosenthal, straight sinus. This is vein of Lavey, and this is the cavernous sinus giving the inferior petrosal sinus. Again, 3D view, superior sagittal sinus, transverse sinus, sigmoid sinus. Here is the cavernous sinus on both sides, giving the superior petrosal sinus. This is the basal vein or basal sinuses. So the superior sagittal sinus is this cavity, small cavity, between the two folds of the dura in the midline. This is we have removed the bone, we are looking at the dura and the superior sagittal sinus. Remove the dura, you would be left with the superior sagittal sinus. And again, you would notice that the veins join the sinus this way, though the blood is this way. As I said, if it was this way, you would die immediately. So they will go this way, slow it down, there are valves here, and then they join the superior sagittal sinus. Looking anteriorly, from right side or from left side, it is just the same. There is always an angle. They don't join it completely straight. Here, I want you to concentrate on this. So people think that there is a vein that will go into the sinus. Wrong. Look at this vein, passing parallel to the sinus and then going into it. You may think this is the edge of the sinus. And here, this vein going this way with this angle. So there are so many variations, and you can only know that by doing the venogram before surgery. That's why I believe strongly that MRI is not enough. MRI is part of MRA and MRV. The three constitute one image. Again, the sinus could have different forms. Look at this, called venous lakes. Look at the venous lakes here, or venous lakes here, or venous lakes here, totally different. So this is the most dangerous area of your body. This is posteriorly, the superior sagittal sinus joins the transverse sinus, the sigmoid sinus, this is cerebellum. And here, there is an area which is devoid of these bridging veins, which can be used safely. Beautiful paper from China, 2007. The dural entrance of several bridging veins. How do they enter? As I said, with an angle. Look at this angle. This way going this way, and then going this way. So this is the sinus, and this is the angle between the two. always acute angle. Why am I mentioning this? Because you will see it in our surgical video. So the veins that join the superior sagittal sinus, we have the frontal, front orbital. We have the group of sinus of a group of veins, anterior, middle, and posterior. And at the central sulcus, we have a pre-sulcus, sulcus, posterior sulcus, and then the parietal, anterior and posterior, and then the occipital and the internal cerebral vein. How many of our residents or newly graduate surgeons know this anatomy? None. Because it is not requested from them to know. The venous system is nothing. So you can cut and do anything you like with it. The cavernous sinus, sending the inferior petrosal sinus and the superior petrosal sinus, vein of Labbe, and so on. Thalamus striate, septal vein, internal cerebral vein, vein of Rosenthal, vein of Galen, straight sinus. So the superficial cerebral veins, which is the superior, going to the superior sagittal group, as I said, are frontopolar and frontal, which is anterior, middle, and posterior. The sulcal, the pre, central, and post, the parietal, anterior, and posterior, the occipital, and you have these anastomotic veins. The main one is the anastomotic vein of Trollard. Here you may think this is an anastomotic vein of Trollard. But look at the variations. We don't have Trollard here. It's a primitive one, where the pre-sulcal vein is very prominent. So are so many variations in this. So reading from a book called Greenberg is disaster, because this is a book that was written by a resident to prepare him for the exam. So he was reading textbooks, major textbooks, and then making his abbreviations for the exam. The problem and the tragedy and the crime is that residents are asked to read Greenberg. This is a crime. It's a book for exams, not for knowledge. If you read Greenberg, you will not know anything about this. Look at this, common trunk, joining all the veins into one trunk. If you damage this is the end of the patient. So the main anastomotic veins are the vein of Trollard, the great vein of Sylvian fissure, and vein of Labbe. These are the three ones. They are called anastomotic. Why? Because they anastomose the superficial with the deep system. Again, there are variations. This is a very beautiful paper from Canada, 2009, showing you the differences. This is the vein of Trollard, vein of Labbe, Sylvian fissure. Different from here. Different from this. This is Trollard and Sylvian. Vein of Labbe is primitive, and so on. So very, very much variations in this. The deep cerebral veins are the internal cerebral vein, vein of Rosenthal, internal occipital vein, precentral vein, and Galen. This is a beautiful picture, and I really regret any resident, I don't envy him, of not seeing this picture in Yazarji. Reading textbook is the essence. Yazarji is made of 5 volumes, mainly 5 volumes. Recently, I think they have made 6. I did not finish reading them up till this minute. So huge. But starting reading them when you're a resident, you may finish them before you die. But don't read from Greenberg. Beautiful picture, 3D. What do you need more? Internal cerebral vein, internal cerebral vein. Thalamostrial vein with the anterior caudal, middle caudal, posterior vein, caudate vein, sorry. And this is the septal vein. They join together with vein of Rosenthal, like this. Vein of Rosenthal starts from the frontal, temporal, and then comes this way. And this is here, you joined with vein of Labbe. This is the septal, this is the forks cerebelli, the tentorium, sorry, with these sinuses inside. Internal cerebral vein starts here, the foramen of Monroe, thalamus striate and septal vein, internal cerebral vein, and then they come and join vein of Galen and vein of Rosenthal. Pseudofossa veins are separate entity. This is occipital view, many veins draining into the sinuses. You should know them exactly where they are and which one you can or you cannot sacrifice. We will come to that in a minute. And the most important is the superior petrosal vein or vein of Danby. This is the pineal gland, and this, the arrangement of the veins here. You cannot do pineal tumors unless you know this arrangement. So this is the value of the venogram. This is the venogram. And I hope that some of the technicians from the X-ray department are here today. Do we have any technician from our X-ray department? None. Although we request them to come so that we can tell them our notes. Technicians. Anyway, so this is the arrangement of these veins and the sinuses and so on. And I used to give a common questions. I put this figure and I say, what is 8 or what is 10? And see whether these residents know. None of them knew. So this is the venogram. And when you study it, you would know what exactly is happening. So you know that there is a vein here. And you would like to know what that is exactly. But this is the accepted venogram. Now we'll show you some of miserable venograms done in this hospital and in other hospitals. We should not accept this level of venograms or pictures. So if there is obstruction of the superior sagittal sinus, you would see the draining veins. And when there is a partial obstruction, there is always a vein anterior and one posterior. Sometimes they are surrounding it. Sometimes they are ahead of it and behind it. And sometimes you get this. And this is called the false or falcine sinus. Again, how many of our neurosurgeons in this part of the world know about anything about the falcine sinus? So, papers, Italy 2005, role of contrast enhanced MRI venography, which is this one. Comparison to see with the superior sagittal sinus. Where are the veins surrounding the obstruction? You cannot go for surgery without studying this. Not only to hang it in the room, but actually know it. Know exactly what are you facing. Tumor, parasagittal, causing obstruction of the sinus. Not complete obstruction, because still you can see the flow. Here there's complete obstruction. Again, veins, almost complete obstruction. You can see the veins. Tumor completely obstructing, and you can see the flow. Another obstruction on the veins. So, falcine sinus, it is like the straight sinus, like this. And usually, when you have falcine sinus, usually there is a problem with the straight sinus. In this view, both are a normal individual. Straight sinus. So falcine sinus and straight sinus. So falcine sinus is also can be present in normal individual. How is that? In utero, on the 20 weeks, when you are still nothing, God create the folks and put some plexus here. This plexus of veins go up and form the superior sagittal sinus, or go down and form the inferior sagittal sinus. This should involute by the time you are born. Sometimes they persist. So it's called persistence of the false sinus. So falcine sinus is a persistence of congenital venous channels within the falls, which closes at birth. They could be normal, they could be associated with some abnormalities or obstruction. Anatomy of the falcine venous plexus, from where? Imagine USA and Iran. So in science, there are no views. There are friends and people, researchers who work together. This is from the University, I think, of Tabriz, Iran, and from Alabama. Anatomy of the falcine venous plexus. Beautiful paper. They show you the channels that connect the superior sagittal sinus and the inferior sagittal sinus. Beautiful. Look at this. The forks and the connections. Different shapes and shades of this falcine. This is the forks, anterior, posterior, tentorium cerebelli. And look at these channels. Important, because sometimes you need to open the forks. And if you don't know this, you will put your patient into trouble, if not death. Beautiful paper from the American Journal of Neuroradiology, 2010, showing you falcine sinus with normal sinus, and showing you falcine sinus with rudimentary transverse sinus. So this is the falcine sinus, rudimentary transverse, rudimentary straight sinus. This is duplicated falcine sinus too. And this is the inferior sagittal sinus draining into falcine sinus. So I have so many variations. Another paper about persistence of falcine sinus from India. We in this part of the world think of the Indians as not up to it, but they are very, very advanced, ahead of us actually, and we should have a huge respect for their people and doctors and surgeons. They are very, very
Ahead of everybody.
absolutely. I mean, the best IT information is from India.
The problem is with their medications.
So falcine sinus, this is the sinus. Please remember this, especially in children. It's very important. Look at this. No straight sinus, just falcine sinus, persistence. As I said, it can be associated with so many abnormalities. So when you see falcine sinus, look for other abnormalities, corpus callosum, agenesis, encephalocele, Abbott syndrome, which is conjointectally and addition of the suture problem, giant parietal foramina, Arnold Chiari, AVM, and aneurysm of vein of Galen. Some examples: abnormal individuals with this suture problems and corpus callosum agenesis associated with AVM, and children with aneurysm vein of Galen, straight sinus, as you can see. Persistent falcine sinus from Korea. You see it here as a dot, but if you look at it here, you'll see it quite clear. Falcine sinus. So this is causing some obstruction, and you would get the falcine sinus. Falcine sinus due to obstruction, thrombosis, venous thrombosis. So it could be normal individual, it could be in abnormal diseases or diseases. Remember, it can be in normal people. So our case for today is this unusual parafalcine parasagittal motor strip lesion. And this is the images of this lady. Parasagittal, parafalcine. There's no obstruction of the sinus, but you look at the veins here. You have to study them because it's important. So what could that be? Any suggestions? Our radiologist first, Dr. Ahmed.
First of all, you have to look for T280.
Sure, we will put the whole images later on, but what would you think of when you see
The first
such?
impression for all, this is a parasagittal meningioma.
Yes, the first impression.
But if you look for T280, it's an intraaxial.
Yes.
Diagnosis could be primary or metastatic.
Okay. Any other suggestions? Residents and neurosurgeons? Anybody? Okay. Let's see. What's the differential diagnosis? Of course, the first one, when you say parasagittal, it goes meningioma. Supracellular, pituitary adenoma, and so on. So meningioma is the first choice. And I choose to put my cases for you. This is meningioma, very much like our case, right? Exactly, parasagittal parafalcine. But these meningiomas can come in different shapes. Again, these are my cases, cystic meningiomas. Cystic meningioma is a grade 1. Meningioma grade 2. Meningioma grade 3. Parasagittal. And this Yemeni girl, histologically proven, falsa. So we're not talking nonsense here. We're talking about proven cases, cases that have been operated and the histology is verified. Rhabdoid meningioma, which is grade 3 cancerous, malignant meningioma. Idiopathic hypertrophic pachymeningitis can look like meningioma. Hemangiopericytoma can look like meningioma. Ewing sarcoma of the dura, very much like meningioma. Plasmacytoma, solitary, not multiple myeloma, histologically proven. Astrocytoma, grade 1 or grade 2 or grade 3, parasagittal, and they are dural based. Glioblastoma. Glioblastoma, one of my patients. Again, glioblastoma, look at this. Again, this is the patient before and after, and this is the histology. Another JBM, before after histology. Same thing with this tumor. Or oligodendroglioma, not astrocytoma, but oligo. Again, based on the midline and broad based and so on. This is oligodendroglioma of this lady I operated upon some time ago. Oligodendroglioma. Oligoastrocytoma, mixed oligoastro. Ganglioglioma, parasagittal, parafalcine. DNET, desmoplastic. PNET, primary neuroectodermal tumor. Epidermoid tumor, epidermoid, parasagittal, looks like a meningioma. And this one, again, one of my patients, 44-year-old male patient with this tumor. I've never thought that this could be an epidermoid. It was histologically proven. Metastasis. Metastasis in the parasagittal parafalcine, yes, why not? Again, one of my patients. Remember the old teaching that metastases usually are small. If you see large, it is not usually metastasis. Wrong. This is metastasis. Huge metastasis from breast. Cavernoma, parasagittal, parafalcine. Patient I operate upon, and this is Queen Rania visiting her in hospital before and after surgery. Intracerebral hemorrhage. AVM, parasagittal. Superior sagittal. This is the most dangerous situation where people think that this is a tumor and they operate upon it. Operate on a venous sinus thrombosis, patient will die. Did I see people operating? Yes. In Jordan? Yes. And they just get away with it. No accountability. You can do any crime you like. Infarcts. Abscess. Tuberculoma, single or multiple. Parasagittal. Tuberculoma. All these are my patients. None of them from books. This is sarcoidosis. Sarcoidosis, parasagittal parafalcine, yes. Neurocysticercosis, parasagittal. And this, another very awkward situation, multiple sclerosis. We think of multiple sclerosis as a plaques, which is periventricular. They can come like a tumor. Okay? Lymphoma, tumor, parasagittal, why not? Leukemia, granulocytic sarcoma, vasculitis, parasagittal, radiation necrosis. How many times we thought of this as a recurrence while it is radiation necrosis? So the differential diagnosis of a parasagittal lesion is very wide, and you have to know it. Stop playing daft about it, saying this is rare, it will not come. It will come. Don't expect that only certain cases will come to you. Any comment, please?
So rare things, when you see enough cases, you'll see enough of them. These are actual cases. This is not a mental exercise. I cannot stress this enough. Yes, the first thing one would think of would be meningioma. And the crime would be to radiate this without getting tissue diagnosis and burying the evidence with it. Because if you mix Ewing's and you radiate it first, the patient will actually miss an opportunity of being cured. So this is a very rare site for Ewing sarcoma, and it can happen. When we see enough of those, you'll see them. And the mainstay of treatment would be multimodality, intensive chemotherapy, surgery, radiotherapy, and then more chemotherapy. And the course of chemotherapy would go on for a year. Plasmacytoma, the prerequisite would be that you've ruled out multiple myeloma, the bone marrow is negative, there's nothing systemic, and these patients would be radiated, would be cured with radiotherapy alone. They won't need surgery, they won't need chemo. Gliomas, if they're low grade, they'll need surgery plus minus radiotherapy. You can delay the radiotherapy until progression. You can use chemotherapy later on when they fail both. And with a high grade, you need surgery, radiotherapy, and chemotherapy with and after the radiotherapy. Oligodendrogliomas, sometimes you can do chemotherapy after the surgery, delaying the radiotherapy, or vice versa. The outcome would be the same. PNET is treated the same as Ewing sarcoma. Again, this is a rare site for PNET. The mainstay would be multi-agent chemotherapy, surgery, radiotherapy, and then more chemotherapy for a course that would last for a year. And I cannot emphasize the importance of not missing metastases. They can be small, and if the patient is not examined and you just operate upon this, or she's subjected to radiotherapy or operation because nobody bothered to examine the breast, that's really a crime. I can't emphasize the importance of not neglecting a diagnosis of metastasis because the lesion is big. Definitely they can present in any way, shape, or form. As a hematologist, not as an oncologist, SSS thrombosis is a medical emergency and it has to be treated promptly, and definitely they should not be subjected for surgery. Is Dr. Montasser in the room? No, but we cannot emphasize enough the importance of not missing tuberculomas in a country of the world or a region of the world that is still endemic, nor abscesses, nor neurocysticercosis. Now, lymphoma in this part would be either a parenchymal or meningeal involvement of a systemic lymphoma that you know that is present, or it would be primary CNS lymphoma. This is not how primary CNS lymphomas present, but when you see enough of those, you'll see this mode of presentation. And the importance of this, these patients would be, the mainstay of treatment would be high-dose methotrexate. No surgery, no radiotherapy. You delay both until you really need them. And surgery would be resorted to if there is impending herniation. Radiotherapy would be resorted to when they fail methotrexate. Granulocytic sarcoma is not a sarcoma. It's a leukemia in an extramedullary site, and it's treated exactly like an acute leukemia and an AML. This would be heavy multi-agent chemotherapy that is myeloablative. This is as intensive as chemotherapy gets, short of transplant. Actually, transplant is kind of easier because you rescue the marrow with stem cells. In AML, you have to wait until the marrow recovers. We keep hammering these points. These are actual cases. These are actual cases.
Please, any questions? Yes.
Okay, all previous differential diagnosis, we will keep in our mind. But
there is a lesion.
Hello.
It could be lymphoma, could be granular
Sure.
sarcoma. Okay, but it needs surgery, so I cannot know if it is lymphoma or other things that no need for surgery if I will not do surgery.
No, you can tell it is lymphoma or leukemia by doing the blood tests. That's why we are against the so-called package deals. These are crimes against humanity. Because if you take a case and say to the patient, I'll take $5,000 or $10,000 from you and I will cover everything for you, you will do the minimum of investigations. You will not do bone marrow. You will not do CBC. You will do nothing. And then you go for surgery. So you can. If you can't, then you can take a biopsy. Or
Yes,
do
sir.
surgery.
I also, there is a lesion making compression on brain, midline shift, increased intracranial pressure.
Sure.
I will go for, not for tissue diagnosis, for biopsy, then I will.
No, don't mix things. Don't. You are mixing things. First page with the middle page with the last page. Your question was pertaining to the lymphoma, and we said that you can diagnose it before going to surgery. But if you have a patient with herniation, and he just said something, if there is herniation, then you go for surgery. Any other comments, please?
Radiation necrosis is very important and crucial for us. I'm Bilal Hawari, I'm a radiation clinical oncologist, ex-army, now working at private sector. Radiation necrosis, we usually face this after irradiation of an area where the 50% of the radiation dose is the brain involved by it. So when we face this, some of the doctors, I have a patient from Iraq, they send it for us for brain metastasis from after treatment of nasopharyngeal carcinoma. I said, nasopharyngeal carcinoma usually will relapse, it's relapsed locally in the nasopharynx or in the cervical lymph nodes or metastasized to the lung. So this is not the area of when Dr. Kakish, Dr. Michel Kakish, he said this is a radiation necrosis, we saved the patient because they was going to operate. The option was, do you want to irradiate this patient or will you go for surgery? None of this, because this is a radiation necrosis and it's very important. Thank you for this slide.
And radiation necrosis, mind you, can occur within weeks, months, or years.
Yes.
I have seen radiation necrosis after 18 years of radiation.
Also, you need to do for radiation necrosis to radiate.
Absolutely. So, our case. Remember this? 64-year-old female lady from Iraq. And recently, people coming from Iraq, you get suspicious about the diagnosis because they have been subjected to so many weapons of mass destruction. While in Iraq, 2007, she had a left breast carcinoma. Again, history of left breast carcinoma does not mean that this is automatically a metastasis, but we have to mention it to you. So 2007, breast carcinoma, mastectomy, chemotherapy. Remained well, and then came for checkup, 2012. She was seen by Dr. Al-Sukhun, and she diagnosed that there are small lung metastases, not very active, but it's better to give chemotherapy. So she gave her chemotherapy. June.
Was this biopsy lung metastasis?
No, it wasn't. No. I'm just mentioning it because out of accuracy.
She wasn't scanned at all at that time, just the lung.
Yes, absolutely.
Because lung is very bad when it goes to the lung.
Yes. So June, which is recent, 2019, she had left-sided weakness. And what did the people in Iraq said? Oh, this is just old age. That's why she has left-sided weakness. Most likely stroke. Stroke is a disastrous diagnosis, which is used just to go cover our ignorance and our lack of knowledge. Left-sided weakness, and then she started having focal seizures and incontinence of urine. With this, you would diagnose that this is a parasurgical lesion. Her left-sided weakness increased, and she fell in her left shoulder. Past history, diabetes, hypertension, hysterectomy due to uncontrolled vaginal bleeding, 2001. Glasgow Coma Scale, 15/15. Mind you, 15/15, and she's having severe left-sided weakness. Again, showing the limitations of a Glasgow Coma Scale. Nurses think that 15/15 is normal. No, you can be hemiplegic and 15/15. Why? Because you can get the best response. Mazboot? Right side, left side. Right side is normal. We take the right side, we ignore the left side. So this lady is 15/15 when she's having severe left-sided weakness. She may have had pupils changes and so on. Vital signs were normal. Ophthalmology was normal. 2/5 power upper limb, 1/5 lower limb. She came to my clinic in a wheelchair with this. She could not move her leg at all. A little bit of movement in her left arm. CBC, bleeding time, kidney functions, liver functions normal, electrolytes normal. Images without contrast. You can see here sulci, gyri are worsening. You don't see it here. Immediately you would say there is something here, something wrong. Contrast, very well defined contrast, very much related to the dura. T2, as Dr. Ahmad wanted. Again, you can see the extensive edema, which is going down in front and everywhere. There's some restriction. Coronal. That's why I wanted the technicians to be here. And I hope that people here would pass the message to them. Why the hell you put this letter here? Because the pathology could be here. So no writing on the image. It's a bad image. It's a bad thing to do. It means that the technician is out of control in that department. As simple as that. Nobody is supervising him or directing him or asking him to do the right thing. Look at this. The pathology could be here. Why did you write on this? H, hospital maybe. I don't know. Coronal, parasagittal, parafarsign, well defined. You can tell that the superior sagittal sinus is patent. Again, P and all along, why? The pathology could be in any part that where you put your letters. The same thing here. And then another disaster. You ask for MRA. What would you get? MRA and MRV on top of each other. Again, the technician is out of control. Nobody is supervising him, and he's doing whatever he likes to do. And most likely he was trained in another stupid place and came to a certain hospital. MRA is different from RV. They should be separate. So this is the MRA, the MRA together. And this is the MRV. Again, here you have to study this area well, because this is where you are going to operate. So we did a few consultations. First thing, when she came to my clinic, I consulted Dr. Ala. And Dr. Ala took her history, and he knew that she had the breast cancer, and somebody treated her for lung metastasis, so he asked for investigations. He asked for chest CT. You want to comment? Or do you want me to?
Yes, no, go ahead. I'm going to comment.
Okay. So these are the small, they were called small fibrotic non-active metastases. 5-6 years ago. And she survived. Abdomen and pelvis were normal. So Dr. Ala asked for technetium scan, which was reported by Dr. Abdulatif. Is Dr. Abdulatif now? He asked him to come over, he did. But basically he said, no clear evidence of any bone metastasis. So again, not because she had CA breast, sometimes the past that this lesion is metastasis. We have to verify this. You want to comment, Hannah?
Yes. So I've had the pleasure of seeing this lady as a second opinion, and they did not have any of the original documents with them, despite me asking for them numerous times. Now, but this lady had a HER2 positive, ER positive breast cancer, which means that she had a lot of options after, as adjuvant after the end of her surgery. So she was on hormonal therapy. And when she was labeled as having a pulmonary recurrence that was not biopsied, as you have pointed out, Dr. Hassam, she was placed again on trastuzumab, which is a reasonable thing to do. And she was maintained on trastuzumab without actual follow-up of these lesions, despite slight progression of them. Now, it is conceivable for metastatic lesions in the era of HER2-directed therapy to remain under control because you have more options for them. But it's really important to know whether these lesions are metastatic or no, because these have implications about the treatment. One, we not only biopsy the pulmonary lesions to make sure that they're breast related, you want to know the hormonal status and the HER2 status. Did it change on recurrence or no? Because 10 to 20% of cases upon recurrence will flip the signature from ER positive to ER negative or HER2 positive to HER2 negative. And so what we asked for was to repeat the CT scan and compare it with the last one to see if there's any progression. And the irregular thing is a simple bone scan that had not been performed for the previous 2 years. But biopsying the metastatic, as you have pointed out, Dr. Hassam, is not only important to document your recurrence or metastasis, it's actually in the world of breast cancer, it's really important to know, did they flip the signature from ER positive to, or HER2 positive to negative, because that has severe implications upon treatment.
Okay. This is the technetium scan. Patient, as she visited Dr. Sana Safan 5 years ago, she went to see her, and then she said, this is the main case to me. She was treated by Amlitex 1 milligram orally by 1 in the past. Is this an efficient chemotherapeutic agent for lung metastasis?
No, hormonal therapy alone for lung metastases is not something I would do.
We asked Dr. Maurice Dahdari to see her. Why? Because she had focal seizure 1, and because she's going for surgery and she may have further seizures. I published a paper about 34 years ago about epilepsy after cranial surgery and compared the epilepsy after aneurysm surgery with other lesions. The incidence of epilepsy after cranial surgery ranges from 3% to 87% to 100% if you have an abscess. So I asked Dr. Maurice to see her, and he said she's integratable at Kipra. We asked Dr. Maurice to come. He could not make it. We asked Dr. Kamal to come to see her. ECG normal, ECMO normal. So basically, she's a low risk for surgery. Dr. Muhammad Juma seen her because she's going to be put on high dose of steroids and their diabetes would flare up. So he was consulted. And Dr. Juma does not believe, as I do not believe in the sliding scale of insulin. This belongs to the past and nobody is anymore using it. But still, we are living in the past using it. Dr. Faraz, as an anesthetist in this hospital, he's the chief anesthetist. He said the patient is fit for general anesthesia. Remember, this is, please, yes, this is an old lady. She's almost hemiplegic, and she is real risk.
Good evening, everyone. My name is Dr. Faraz. I'm an anesthesiologist working at Farah campus. Thank you, Dr. Ibrahim. I can't thank you enough again and again for your informative lectures. I just want to stress out about the parasagittal tumors or masses for my fellow anesthetists and people who work in the theater. Whenever I see the word parasagittal, to be honest, I get really scared and mortified. The implications for anesthesia is not only preoperatively, but also intraoperatively. That's why we have to know our anatomy as well as the neurosurgeons. This lady had a mass close to the superior sagittal sinus. So you would expect massive bleeding. And then these sinuses, actually, they are not collapsible. So if one of these sinuses actually is opened intraoperatively, that means we are bound to have a massive embolism. So we have to be aware and we have to be knowledgeable about our anatomy. And as you can see, this lady was a very complex case. And I would like, and I appreciate what Dr. Ibrahim is doing and what he's teaching us every day about multidisciplinary team meetings and consultations. Thank you.
So what are the challenges in this case? Parasagittal, whatever, we don't know the lesion yet. We don't know the pathology yet. Is it meningioma? Is it whatever? What are the challenges of being in the parasagittal area? Tremendous. You may end in death on table, you may end with hemiplegia or on a ventilator. The position of the lesion, is it anterior part or middle part or posterior part of the superior sagittal sinus? Whether or not there is edema, like in our case, whether there is a sinus invasion, whether there is a brain invasion, whether there's a vascular invasion. And vascular here means veins. So this is game of veins, or Game of Thrones, if you like. You see this TV series, Game of Thrones. This is the game of veins. Position, is it in the anterior parts, or middle parts, or posterior parts? Each has its own challenges. Or it is at the junction of the superior sagittal sinus and the transverse sinus. We may present a case of falcotentorial meningioma in the coming future. What is the relation of this lesion to the pyramidal tracts and the sensory tracts? And here comes the value of navigation, which I will allude to. Edema, because edema will not allow you to do dissection. You would not see the structures well. And you could see in our case extensive edema. So this is really a challenge. This is our case. Look at the edema, look at the brain almost bursting with edema. And what is more, there is this vein coming this way and running parallel with the superior sagittal sinus. This is the superior sagittal sinus.
Why is there edema? Why is there so much edema?
So this is the midline, right side, left side. This is the brain edema. And this vein, congested vein, going this way, this vein joins this vein, and they go parallel to the sinus. And the lesion is here. How can I get in?
How come there's so much edema?
The lesion has caused this.
It's just because of
Yes.
obstruction.
And if you see, no, we showed that there is no superior sagittal sinus obstruction. This is intrinsic, caused by the lesion, edema of the brain surrounding the lesion. And if you see such a thing, you think of bad things. Metastases, abscess, glioblastoma, and so on. I choose to put this paper by my friend Roberto Heros. Roberto is from Cuba. He's in Miami. He's a famous surgeon and visited Jordan many times. And I'm quoting him here. Venous sacrifice combined with the brain retraction is associated with major brain injury. World in Neurosurgery 2013. Vinko Dolans from Ljubljana, Slovenia. Again, a friend of, very much a friend of mine. All the veins should be preserved during surgery for whatever brain pathology you do. What do we teach our residents? On vein. Who cares for a vein? Veins are nothing. Veins are Canadian. They are nice. Well mannered. They don't do anything for you. You coagulate them, they do nothing. But then 6-8 hours after surgery, in the early hours of the morning, the patient is unconscious and hemiplegic. He will go out talking and doing everything, although he clipped some of his veins. 6-8 hours, you will have a disaster. So sacrifice of any of the sulcal group of veins in the middle of the sinus is calling for a disaster. So when you have an obstruction, these veins are very important. So this is the parasagittal, and this is the dure, and this is the tumor. Veins, they sometimes run through the tumor without you knowing. So you think they are on the surface? No, they can go through the tumor. So you have to dissect them like we did here. This is the sinus. The lesion was here and this vein was dissected. How do you dissect it? You dissect the arachnoid and make it relax. Can you do this with the naked eye? No, this is a microscopic surgery. Are there still surgeons in the world using this surgery without microscope? Oh, yes. In Jordan, in the Arab world, and in this area of the world. Look at this vein, which, like in our case, is going two veins joining, and then they are parallel to the sinus. But you can dissect this and then find the space so that you would go in. Can you do more to preserve these veins? Yes. The paper is from Italy, venous sacrifice in neurosurgery, new insights by injecting indocyanine green video angiography. What is this? Indocyanine is IV injection that as you are working, the anesthetist will give it to the patient, and your microscope you have installed in it this program, and then you switch the lights of the microscope and you see the veins like this. Beautiful technique, which is used in aneurysm surgery. Dr. Abukafi just came from China. Yes?
Yes.
And Dr. Husseini from Finland is there. Does he use this technique?
Sure.
So this is a routine thing in aneurysm surgery, and it should be actually popularized in other surgeries. Another complication that nobody thinks about is mutism after removal of anterior forcine meningioma. Oh, how come? This is on the right side, the speech area is here, and people get out mute. Because here we have the so-called supplementary motor area. People don't think about. Anatomy of the brain is not taught in this part of the world. They are taught to take discs out, to put screws in, to put shunts in. So we got her consent. Again, detailed consent, detailed for the patient condition. There is no universal consent form. How many times did we say this? And we keep repeating this. Everything that the patient has is different from any other patient. And the signature, of course. Wali Amr al-Marid. And we use the navigation. We have the navigation people here, Sayyid Hamza, and Sayyid Nasib Jarar, and Sayyid Hamza from Jihad Saleh. We use this navigation for this purpose. We are on the motor strip. We know our anatomy, but we need something more to give us confidence, especially with the veins that we are going to face. Again, this vein joined by this vein, both running parallel to the sinus, and there is this another vein also running. Tumor is here, and the brain is edematous. So let's see the surgery. So I know exactly where I'm going. So I have to relax this vein by cutting the arachnoid around it. If you don't do this, the vein will be stretched. But if you take the arachnoid around it, then you can mobilize it. So I'm mobilizing the arachnoid, removing it so that the vein would be mobilized. You cannot do this with your naked eye. You need 12-15 magnification. So there where the vein goes into the sinus. So where to go? Edematous brain, vein obstructing your view, and this is the norm in the middle of the sinus. You will always find this bad arrangements of veins, and you have to be ready for it. Residents and young neurosurgeons think, oh, parasagittal, it's easy. It's under the surface. No. So I'm trying to go here. I cannot mobilize more. I'm trying to go in here. Let's see whether we can succeed and what do we find. The brain is pulsating. We have given everything. And then I will not start screaming at the anesthetist, oh, you are bad anesthetist, I have brain edema. There is a major lesion here. The anesthetist has nothing to do with it. Lots of neurosurgeons, mediocre neurosurgeons, young neurosurgeons start screaming at the anesthetist. Instead, it has nothing to do. Your technique is bad. Behave yourself and act quickly. So this is the vein. Again, running parallel to the sinus.
That's tumor.
No, this is a vein.
No.
The tumor is inside. It is inside the cortex. So it is not extrinsic. I'm just still trying to find out. Now I'm trying to retract the brain. I'm seeing the folks. There's no lesion outside. So this lesion is intrinsic. So I excluded immediately meningioma. And I put the navigation and I knew that I'm in the exact position. I covered this vein and I'm working between this vein and this vein. And you can see the tumor, vascular tumor, very vascular. And vascular tumors are usually metastatic, usually. When I see visits like this, look at these veins coming from the folks to the tumor. The worst metastases to bleed are the thyroid and the colon. They bleed like hell. The worst ever is the thyroid. So there's no good plane of cleavage, although you have seen that the lesion is well defined, but here there was no good plane of cleavage. And you have to remove the tumor piece by piece. Are there still neurosurgeons in Jordan and in the Arab world and this part of the world that put their finger and take the whole thing out? Yes, because they are careless, they are not trained, and they are mediocres. So step by step, you want to remove. Remember, you are on the motor strip. Here is the arm area, here is the leg area, and the urine incontinence control area. So whatever you do can damage the patient. Notice that I'm stopped using the retractor here. I want to give the patient the best chance possible. Here, starting to reach to the white matter, but still you have to cut the blood supply coming from the forks. It will continue to bleed till the end. So whenever there is a bleeding, I know there is still a tumor. I would not stop so long there is a bleeding. It means that there is still a tumor. Patiently, this is the patient discharged. Tumor is friable, vascular. Here is the white matter. So you have to start the mopping process and controlling the bleeding. But look at the edema, it has subsided already. And this is the cavity of the tumor. Look at the cortex coming back, and this is the vein. And this is the other vein. So we were actually in this slit, small slit, and this is the hemostatic material that we use. Okay, can we proceed? This is just our hemostatic tissue that we put. Histology, Dr. Professor.
I want to mention two comments. This was metastatic breast carcinoma, but I have two comments, very important comments about breast carcinoma metastasis. Actually, when I was a fellow at MD Anderson Cancer Center in Houston, Texas, I did a very good project about the prognosis of metastatic breast carcinomas. Metastatic breast carcinomas, when it goes to the lung, it is the worst. Usually the average survival was 6 months. So I was very much astonished when they said that she has at 2012, she had lung metastasis, and now 2019, she's still living. It's of course wrong. This is not a lung metastasis, because lung metastasis, they don't survive for 7 years. Astonishingly, the best survival in metastasis is when it goes to the bone. Some patients with bone metastasis breast, they live 10 years, while lung metastasis is the worst, is 6 months. Brain metastasis is better than lung metastasis, is 2 years. So I got to know firsthand, or with my project, how really tumors they behave. So this patient has, if this really has lung metastasis, which was not biopsied in 2012 and treated as lung metastasis, this presumably was not a lung tumor because it cannot be lung tumor for 7 years. The other things I want to mention, the other comment is that not all tumors, they go to the brain. Not all malignant tumors, they go to the brain. The most common malignant tumor in females that go to the brain is breast. The most common in males is lung and then colon. But other tumors, other malignant tumors, they don't go to the brain. Yeah, like what Dr. Bilal mentioned, nasopharyngeal carcinoma, usually they don't go to the brain. So you really have to know the behavior of your malignant tumor before you calling it metastatic to the brain. This case was sent to the frozen section, and I knew that she had breast cancer, so I called it immediately that this is metastatic breast carcinoma. You can see how this tumor is arranged in a cribriform pattern with a gland formation. Again, you can see how the tumor is arranged in cribriform pattern with necrosis, and this is the tumor trying to form glands and poorly differentiated. Again, you can see the glands here. And here, there's mucinous component here. You can see very clearly that this tumor is producing mucin. Again, you can see the mucin and that these are the cancer cells. This tumor was estrogen positive, 20%, and progesterone positive, about 50%. HER2 is negative in this tumor. You can see this is very important for all people that or heard about HER2. HER2 has, you can see this is the positivity. But when you want to call something HER2 positive, it has to be complete membranous pattern. Yani all the cell has to be completely positive. And you can see there is almost no cell or very few cells that are positive completely. Yani this cell is positive from this side and this side, but negative in this side. So we cannot count this cell. It has to be 10% of the cells completely in membranous pattern positive. This case, you don't see very rare. This is in one cell that's positive, but much less than 10%. So this is we considered +1, and this is considered negative in HER2 staining.
So she did.
So
she was positive. She was positive.
This patient was not positive. This was patient that's negative. With this patient,
6 years ago.
I don't know about the years ago, but I know that in this case, this patient should see, for example, this case, this membrane is not completely inserted.
No, I understand. Yeah, I'll comment upon this. It's common to change.
There are two things in HER2. There are two things important for pathological about pathological points. One thing that they can change. The other thing is HER2 is heterogeneous. So it can be in one area that was positive originally, but the metastasized part is not positive. So you want, it's very well known, HER2 staining can be heterogeneous. So the breast, it has to be really in good selected size when you do HER2 staining. But this again, I just want to, this is for teaching purposes. For example, this is, you see the membranous pattern, but this is not a complete cell membranous pattern. This is negative. Or this is another one. It's negative from here. So these are not considered positive. We have HER2 either 0 or 1. These are negative. 2 is equivocal. 2, when you have 10% of the cells with mild to moderate cell membrane staining pattern. 3, when it is strong and complete in more than 10% of the cells. This is very crucial because time and time again prove this is a very great value. Case 7 was in this case about 25%. This is complete, but I'll show you. This is one of the examples, not in this case, complete staining pattern of positive HER2. You can see it's more than 10% of the cells, and it's surrounding the whole cell membrane. I just want to tell you some notes, about, very important notes from pathological point of view, classification of breast tumors. Not all breast tumors, they behave the same, because we at least have 5 different types of breast tumors. Some of it depends on the hormone receptors, estrogen and progesterone, we classify them. It depends on the HER2 status. If the tumor is negative for estrogen, progesterone, and HER2, these are usually basal tumors, and we call them triple negative. Yani negative in all HER2/neu, ER, and BR, and they behave differently. I will show you some studies in this one. And it's very important to do proliferation genes, which are the key 67 in these cases. Hormone receptor-driven tumors, why it's important? They represent majority, 2/3 about of breast tumors. They are classified as luminal. When it's ER, BR positive, classified as luminal. It depends on how much ER and BR expression. The more ER expression, the more BR expression, the better the prognosis in this patient. The lower probably count not to be luminal A, it's going to be luminal B. Luminal can be A and B. And
estrogen and progesterone.
yes, estrogen and progesterone. They are heterogeneous, could be a heterogeneous group regardless of what. And they are divided into luminal A and luminal B. Luminal A is the best prognosis in all breast cancers. Luminal B, they don't behave in a good fashion. So it's very important, and they are differentiated according to the percentage of ER positivity, BR positivity, and the key 67. Key 67 is very important in these cases. And they are divided, I mentioned, by key 67 proliferation activity and percentage. So breast cancer is not one tumor. You have to know everything about it to really know the prognosis. Very important things also, you have to know about ER, BR. BR actually is not helpful for treatment. BR is helpful for prognostic value. So we do ER for treatment, estrogen receptor for treatment, but BR we do it for prognostic value. If the BR positive, this is carry better prognosis than BR negative, but treatment-wise, it will not change. So it's ER positive cases, BR negative, likely to respond to aromatase inhibitors than tamoxifen. This is important. Differential response to chemotherapy, we define them. The more ER positivity, the better response to endocrine therapy. But the more BR positivity, the better prognosis. A very important thing about BR. If you have a case that is BR positive, it has to be ER positive. Actually, this simple piece of information is not known by many, even oncologists. And I was in a meeting like 1 week ago, and one oncologist asked what the prognosis of BR positive cases, ER negative cases. These actually cases very, very rare, and usually there's something mistake because BR has to be positive. When BR positive, ER has to be positive because they are in the same pathway. You cannot get BR positivity without getting an ER positivity. This is very important piece of information. This is also very important. You will know how the different breast cancers they behave. احنا كنا حكينا انه there are at least 5 types. شوف triple negative cancers اللي هم ER negative, BR negative, HER2/neu negative. Most of the time when they relapse, they relapse in the viscera. They go to the liver, they go to the brain. This is the usual way of metastasis. When they are AR positive, the usual way of metastasis is usually in the bone. The most common types to go to the bone is the ones that are estrogen positive. And you remember in my study, they show the best prognosis in bone metastasis. They live up to 10 years. So really, it's a good prognosis because they are, and when they metastasize, they go to different sites than our good prognosis sites. HER2/neu is bad prognosis, and they go also to the viscera. This is another very important care. الأزرق هو اليومنال, البلو is the luminal A, الأصفر اليومنال B. This luminal A and luminal B, blue and yellow, are ER and BR positive, but the luminal B has more proliferation. You can see the prognosis تاعهم after 10 years they are تقريبا 80% of luminal A surviving. لكن شوفوا patients that are HER2/neu enriched, they are very bad, one of the worst. البازل when they are triple negative, يعني ER BR HER2/neu negative, the worst years for them اللي هم الأحمر, the worst years for them is up to 3 years. After بعد 3 سنوات if they survive without recurrence, they will have a very good prognosis. These pieces of information are very, very important for a clinician to know, because that's why we really got different, emphasize the importance of ER, BR positivity.
Sam, this is an extremely important slide, as you pointed out, because it emphasizes that, what I'm going just to say now, is that breast cancer, regardless how limited it is representation, it continues to relapse and relapses late. And even in the best group, the luminal A, they continue to relapse and relapse late. And the other groups, more than 50%, and when you follow them long enough, they continue to relapse. This pattern of 8 failures in best is always there, even in the best of groups. I totally agree.
Thank you, Dr. Sam. Always great. My comment is about the lung cancer you mentioned. You said that this is maybe not a lung cancer, but you have to put in your mind that this is luminally and it's ER strongly positive at that time and now. And she was treated for at least 5 to 10 years with hormonal therapy. So she was under treatment until she relapsed. So
she was also HER2-directed therapy as well.
Yes.
But I think Dr. Hassam's point is also well taken. When you usually fail and they present in the lung, it doesn't remain indolent even on HER2 treatment that long. And usually it gives you more trouble. And you'll see exceptions, of course. I mean, usually, but when it will give you more trouble.
We can discuss this.
Let me finish. The last point I want to mention, one of the clinicians that are caring for the patient, he asked about the status of the margins. And I think he doesn't know how the biopsies or how the brain resections are taken piece by piece. So really, in the tumors of the brain, we cannot assess margins because we receive them in pieces. And I think Dr. Ibrahim probably will highlight on this case.
Radiation therapy because there's a lot of micrometastases in the brain.
So again, this slide, and I'm glad that we stopped here because this slide stopped the presentation here. Dr. Hassam's part. This really emphasizes the point I've been making. Breast cancer continues to relapse even when it presents in early stages and it relapses late. It is irrespective of which subgroup you are, even in the best of ones, they continue to relapse and relapse late. And in the worst groups, more than 50% of them are going to relapse. And there's really no plateau on this. They continue to relapse and relapse late. And the Bonadonna trial with the longest follow-up in early stage breast cancer have demonstrated this when you evaluate these long enough. Now, for those, this patient was labeled as HER2 positive at start and ER positive. And there was emerging data after the introduction of trastuzumab in the early part of the millennium that when these patients are followed long enough, they do get brain metastases. And there's a lot of talk about why that may be. It may be because you're controlling the disease longer and these patients are living longer to the extent that they're getting more a chance to get brain metastases. Now, we did not have the original specimens to review to confirm whether this indeed was HER2 positive or no. But it does not surprise me when they actually flip to HER2 negative when they have a brain metastasis. And the chance of this happening is in 10 to 20% range. The reason why this is really important is that if this is positive, these patients would benefit from oral HER2-directed therapy in addition to oral capecitabine, both of which are well known to penetrate the blood-brain barrier, which would have been what would have been recommended from a chemo perspective, biological perspective for this lady. The fact that the brain lesion is HER2 negative is very important because you would not use HER2-directed therapy, and indeed there would be no reason or rationale to continuing systemic HER2 therapy. This patient will need radiotherapy to the brain to be followed by capecitabine-based chemotherapy because of its ability to penetrate the blood-brain barrier.
What makes these people, I mean, breast and the thank you all for your informative talk. But what makes the lung and the breast cancer, what entice them to go to the brain rather than for more than the other cancers?
That's an excellent question. Now, what makes certain cancers go to a specific part is an extremely interesting thing. Why do they home to specific areas is a very interesting thing. Breast with the pattern of going to bone as opposed to lung, liver, and brain. Now, breast is a very common malignancy, so it's the most common in Jordan. It's the second most common in the world. Now, it's second to third. The issue is that you get more metastases because of that number. But even then, that predilection is something to do with the homing of the cells. It gets more complicated when you try to explain something that's even harder to explain. Why would you have things like primary testicular lymphomas that would home to the brain, while you get primary CNS lymphomas that in an organ that doesn't have lymphatic tissue to start with? Why do testicular cancers, other than lymphomas, metastasize to the brain particularly? It has to do with embryology, histology, where do they home, how do they home, and the signature. And the short answer is we don't actually understand why does follicular lymphoma, why does thyroid cancer in particular home to the bone and the brain? Those kinds of questions. It has to do with every cell type, the embryological derivation, the histological signature, and the changes in the behavior of the cell as part of the oncological process.
Can we continue with the case and then we'll continue the discussion? This is the diagnosis. Finally, this is metastasis from the breast, and postoperatively, this is an MRI. Mass is being removed. Edema, of course, is still there because this is the next day of surgery. So still edema. She's immediate. Look at her. She's still in the ICU. She started to move her left side. We discharged her after 4 days in the hospital, and the discharge summary should be complete and extensive like we do in every case. And we insist that discharge summary starts on admission and you finish it just before the patient goes home. And I stop at this. We have to respect patients. We have to respect that they are human beings. So follow up at my clinic, Saturday, date, Saturday, 2 p.m. Follow up with the Tomaris, Wednesday, date, time, and so on and so forth. So you have to do this for patients because they're human beings, respect them. مش تعلي على عيادي خلاص. This is her when she came, sitting in a wheelchair and unable to raise or move her left side. And this is how she went back to Iraq. Thank you very much.
For since it's well known that this can metastasize in the brain, why was she not, at that time, when they found it in the lung, why was she not scanned in the brain as well? I mean,
It defeats my intelligence, as usual. Why these people are behaving like this?
I mean, it's well known.
We have to admit our shortcomings and our, I can't say more. People are needed more, or need people to learn more and to act according to proper medicine. Proper medicine is not practiced really in this part of the world. Any other questions or comments, please, Dr. Ahmed?
Thank you, Dr. Ibrahim. First of all, in this case, it's very important to differentiate whether the tumor is intraaxial or extraxial to know our differential diagnosis, because it's an intraaxial tumor and our differential diagnosis could be primary metastasis or inflammatory.
Sure.
Second thing is, if it's metastasis or primary tumor, we can differentiate it not in conventional MRI. We can do complementary perfusion and spectroscopy. In perfusion, we can differentiate between primary and metastasis, since if we do a relative cellular volume around the tumor, it's normal in metastasis, but it's very high in the primary brain tumor. Second thing is the MRI spectroscopy. MRI spectroscopy, choline, and intratumoral and peritumoral is high in primary brain tumor, since there is a neoangiogenesis, but it's normal in metastasis. I want to answer the question by my colleague, why there is a massive edema. Because this is metastasis. Since it's metastasis, it's a foreign cells, it's not a glial cells, and reactive will be very high. Small tumor, very large edema.
So it's reactionary.
Yes.
Yeah. Allow me to attack you and Dr. Roger. You just said that we need to do
Spectroscopy and diffusion.
spectroscopy, and this patient had MRI here. Why did you both not do the spectroscopy? We have 3 Tesla, and it is equipped with all these facilities. Why are we not using this facility?
Because you have to ask it. Because the technician, if you don't ask, he didn't do it.
No, of course I shouldn't.
It's routine.
It's routine.
Because sometimes it's very costly.
No. I mean, I don't accept this argument. It is necessary that technicians and people know that this is the routine, the norm that should be done with the 3 Tesla. Any other questions or comments? If not, thank you. We'll meet next week.
Okay, I think we're going to have a question or two with Dr. Ibrahim. Ibrahim, can we ask you a question or two?
غير التايم المره الجايه دكتور وحيد لانه شتوي 7 بالليل
بقول له 6 ما تسهل في صلاة هذا بس صلاة ترويح الصلاة هذا
مريض
Hi, good day, Dr. Ibrahim.
Hello.
Thank you for another excellent multidisciplinary presentation. I'd like to introduce you to Mazen Abouadad. He's a neurointerventional radiologist from Naples, Florida. Mazen, do you have a question or comment for Dr. Ibrahim?
I just want to say good evening. Hello. Very impressive. Really enjoyed it. It was very informative. Thank you very much for the presentation.
It's a pleasure.
I enjoyed the whole thing, but especially the first part about the cerebral vein, because this is not a subject that a lot of people discuss or talk about. And I like your point.
Thank you. Thank you very much indeed.
Very good. Thank you, Dr. Ibrahim. What is the topic for next week?
I was thinking of presenting a foramen magnum lesion.
Okay. Okay, very good. Okay, we'll see you then. Thank you very much.
Thank you all. See you next week.
Bye-bye.
Bye-bye.
Yeah, we don't want to keep them too. I stopped recording, Mazen.
Thank you.
Yeah, but these webcasts are good for networking. Now, you're a neurointerventional radiologist. I looked briefly at your resume. Are things settled down there in Naples as far as stroke center, and whether you guys are leaving mass exodus or what?
Yes. What happened? They ended up getting rid of the CEO who was causing all these problems, and so we have a new administration. And so the board of directors talked to me, and I came back. So now we provide the service here. Things are stabilizing, and well, actually, I just finished doing stroke case just before the meeting. So,
okay.
Yeah, things are going well right now.
Okay, so it's a stroke center in Naples.
Yes.
It's the only one around in Collier County, right?
Actually, because of the issues that happened, I ended up leaving NCH. At that time, it used to be the only stroke center in this region. But when I left briefly, I ended up starting another stroke center at the other hospital, Physicians Regional, which used to be a Cleveland Clinic hospital. And then after that, came back to NCH. So now we have stroke centers at both hospitals.
Okay.
I have 2 of them now.
Yeah, I know that there's a problem that with the ambulance drivers, because they don't know whether to take it to this place or that place. Stroke patients.
Yeah. No, I mean, we try to do what's best for the patient. Like from our part, we cover both hospitals, so it doesn't really matter.
Oh, you cover both? Oh, so it doesn't make a difference, really.
Exactly, for me, yes. So we tell the ambulance and we educate them all the time to take the patient to the closest stroke center. So,
okay.
Yeah, that's what's best for the patient.
Yeah, okay. If you want to have any conferences or run do a webcast.
Okay.
Maybe for your ambulance people, if you want to do one, You know, like a talk aimed at ambulance drivers, or to the general population, or the medical whatever audience you want to hit. Just let me know, and we could do a webcast.
How do I do that? How do I get a
Well, what you do is just give me a date, a good date that you want to do it.
Okay.
And you do a presentation, much like Dr. Sabea did. You may have maybe have a PowerPoint, or maybe you can just wing it, whatever you want to do.
Okay.
And then open it up for discussion. But you know, first is arranging a time so we can promote it and tell people on this day, you know, and you know, like if it's ambulance people, getting to all ambulance people, you know, just basically trying to get the audience aware of what you're going to do.
Okay. Okay.
It's not going to be huge numbers, but it's a start.
Absolutely. No, I agree with you. So
no, I know what you're going through. Like in Argentina, there's neurointervention radiologists, you know, struggling to educate the public, and there it's worse than the United States. They don't even have any idea about stroke treatment, and they didn't know that there is such a thing as stroke centers.
Yep.
In Buenos Aires, there are.
Yeah,
just don't know about it.
Yeah, time is of an essence with stroke, and that's actually our biggest problem, is getting the patients to come to the hospital as soon as they start having the symptoms. And usually, like the patient I just treated, he was last seen normal last night at 9 p.m. and here I am treating him at 10 o'clock this morning. So
okay.
12 hours later. I mean, luckily everything went well, and we were able to do the thrombectomy, and he's back to normal. He's able to.
Oh, great.
Yeah, but we're not lucky all the time like that.
Oh man, I remember working in the ER. There was nothing you could do. You know, you just put the person in the corner, start an IV, and call a neurologist, and he'll say, "Well, call me when the CT's done."
Not anymore. Things have
changed. But in the world, in large part of the world, that's the way it still is.
Exactly, I totally agree. And actually, I'm actually planning on going to Jordan because I am originally from there. And
where are you from?
Jordan.
Oh, you're from in Russia?
No, Jordan. Amman, Jordan.
Oh, you're from Jordan. Oh, that's why you know Dr. Sabea. And
yeah, that's why.
Okay, I didn't know that.
Yeah, so I'm actually supposed to give a talk for them when I go there in 2 weeks.
Oh, cool. There's a conference in Jordan?
Yes. It's going to be
great
a venue, I think.
Great. Is it Dr. Sabea involved or no? He's not.
Probably, I don't know. Probably
okay.
It's maybe the same place and everything.
Oh, it's at Amman Medical Center?
Yeah, at the Farah.
I have no idea if he would be involved or not.
Yeah.
He's been doing these multidisciplinary presentations for 27 years.
Wow.
It's very unusual. You know, there's no one else I know that does a multidisciplinary. Yeah, and you know what that is, right?
It's very
different specialists. I haven't seen it. Maybe some other neurosurgeons do it, but I don't know of any.
Not in neurosurgery. I've never seen that. No.
Yeah, and 27 years though he's been doing it.
Time.
Yeah, he's a dedicated guy. He really enjoys doing it. Internet's kind of new to him. It took him a while to try it, but we've done about a year now of every week, every Wednesday, 7 o'clock.
Wow.
He does a presentation, and slowly, it took us a while to get him to speak to the audience, speak to panelists like you. But he's starting to do that now too. So,
I mean, that's a lot of work.
Yeah.
Every week.
Yeah. Well, it's his passion, you know how some people just like to teach. That's just like it. They just enjoy it.
Yeah.
And it probably gives them a little credibility at the hospital. And he invites people. He introduced me to a really big back spinal neurosurgeon from Jordan. I believe you probably know who he is. Hold on. Dr. Ahmed. Hold on. We did a webcast with him a couple of days ago. Okay.
So he's a spinal neurosurgeon.
Yeah, let me show you we have a Jordan channel. I'm going to screen share this. This is my presentation here. Okay, this is a neurosurgical TV. We just broadcast that on the front page. Now the Jordan channel is, we have a neurosurgery channel we have here. And I'll show you all the webcasts we've done with them. 31 webcasts. Ever since September 26th of last year. So we've done it for more than a year. And the neurointerventional, we have a neurointerventional channel too. Let me show you that one.
Oh.
We've done, I've done the Spanish conference for 4 years now. Neurointerventional radiology. Here's the last 1, 2, 3, and this year is 4 years in a row. And you probably recognize some of the names, I'm sure. Demetrius Lopez, Rob Abrams, Hanel from Jacksonville. You probably know him.
Ricardo Hanel. Yeah, I know.
Yeah, Nasi Koser. Don't recognize. Oh, that's a Mahoud Mirza, Itzhak Hudak, Italo Linfanti from Italy.
We work with Italo. We work in the same group.
Oh, okay. Okay, so you know some of these people. Hans Henkes, there's Demetrius Lopez, Yasumoto from Japan.
Yeah.
Apparently he's big in Japan. As you know, it's not a big world in neurointerventional radiology.
No, it's not.
Everyone seems, the people at the top know everybody.
Yeah. So to get a hold of you, how do I
let me give you I'm gonna give you my email address.
Yeah.
I know you're not on Facebook.
No, I'm not on Facebook. No.
That's fine. Okay, you see my email address? Hold on. I put it in the chat box, desertedbeach@hotmail.com. That's the best way to go hold of me. And just give me a date. The weekend's probably the best. Give me a time, Saturday or Sunday. That would be good for you. Give me a couple of possible dates would be good. If you give me a 2-week lead time, say, I want to do it this day. I can do it at this time. What's best? And then then the next step is to make a poster, which announces the event that you can send to the people you want to see, and I send it to the neurosurgery community through Facebook. So hopefully we'll get some people to come and get you to become acquainted with the platform. It's a very powerful platform. I think it has a lot of potential for education, especially in the stroke field, because as you mentioned, it's a problem of education of both patients and ER docs.
Oh yeah.
And it's an education because it's there. Yeah. People just got to know about it.
Yep. Yeah.
No, so anyways, I'll be glad to work with you doing that.
Okay. Let me ask you: is there a cost for that?
No.
Oh,
no.
Really?
No.
Okay.
No, maybe someday when we're getting more professional now. As far like now, we got a backdrop, and we do promotion, and however, we have to get professional as far as production and etc. before we start charging. Okay. So it's basically a learning. Like I'm an internship. I'm in residency now.
Okay.
And learning this technology, and when you're in training, you really can't charge. You look down the road. I'm confident I'm going to make money down the road, but in the meanwhile, I got to put my time in and learn this craft.
Yeah, and build the infrastructure. For
Yeah, build the infrastructure. Because, you know, America especially, they wouldn't accept poor quality video and sound. Look, sometimes our sound's not great, and they wouldn't accept that in America anyways. So I realize that. So I'm just in training essentially.
Yep.
You know, with Dr. Lopez and Dr. Hanno, we did one of their conferences, and it wasn't really, I didn't charge, but it wasn't really, the sound wasn't very good, and we had to cancel some videos and stuff. But, you know, they realize that. And to get to the big time, though, where we charge every time, we have to get good, very good quality stuff.
And in terms of presentations, I guess I just upload my slides from.
Yeah, I'll show you how to do it right now. Yeah, you have any PowerPoint now?
Yeah.
Okay, what you do, okay, you open the PowerPoint, like go to another screen and open the PowerPoint on your desktop. You have a desktop, right?
Yeah.
Yeah, just open the PowerPoint on another screen and leave it there and come back to the video.
How do I? Oh, here.
Just open it. Open the PowerPoint.
Yeah.
And then come back to the video. Did you open the PowerPoint?
It's opening right now.
Okay, now come back to the video. At the bottom of the screen, there's a share button with, you see the share?
Yeah. Hold on.
Okay, click on the share button, and there you're going to have 6 options of which screen you want to share. Pick your PowerPoint that you want to share.
It's still downloading because I'm downloading it from my
OneDrive. Okay. It's a big PowerPoint or videos?
No. I mean, it's got a video, yes, but it shouldn't take that long. I don't know why. Let's see.
Excuse me.
Oh, you have some bad cough.
No, it's just temporary. You know, the AC drives me crazy in Florida.
Oh,
you know,
yes.
Yeah. Once it gets cold and hot, and oh man, I get sick all the time.
Yeah.
So it's not serious.
Okay.
Yeah, okay. Yeah, talk to my brother.
Oh.
Hey, Kurt. Hey, Kurt. Can you hear me? Kurt, can you hear me? Are you ready?
Yeah,
Okay, click on the share button.
I did. Yeah.
Okay, now there should be 6 screens opening up in front of you. Pick the PowerPoint. Do you see the PowerPoint in front of you?
Yes, I do.
Okay, click the PowerPoint and click share at the bottom. There you go. Okay, now you own the screen. You can take us wherever you want. Okay, and the power. There you go. You got the PowerPoint in full screen mode. It looks nice.
Yeah.
To go to the next slide, that's what you do. To go backwards, you know how to do that, right?
Yep.
Okay. And that's basically it. And when you have a video, do you have a video that has audio?
I do, yes.
Okay, go to the, now we have to set it up correctly for the video, but go ahead, open the video.
Hold on just a second, we go through that. Yeah.
Okay. Now, do you want the audio to play so the audience hears it?
Yes.
Okay, so we have to go back and set it up for that. So go back and get off the screen share again. So let me show you how we set it up. Just put stop screen share at the very top. It says stop screen share.
It wants me
Is there a stop screen share at the top of your screen? It says stop screen share.
Oh, I see it, yes.
Yeah, stop, okay. Now let me show you how we set it up when you have video with audio. Okay, do the same thing you did before. Click the share button.
Okay.
Okay, when you see that screen open at the very bottom, it says share computer sound.
Oh, I see.
So make a click on there.
Yep.
And then pick your PowerPoint and share.
What about the second one that says optimize?
Well, you can or can't. It doesn't matter. Either way.
I'll just do it. And then I'll select.
Either way, it doesn't matter. It's going to play with. Okay, now you're at your PowerPoint. No. Start sharing again. Okay, there you go. Now you play it. You should hear the audio when you play it.
Here.
What's this right here?
Same. That's the TPA syringe.
All right.
188 over 87. Go ahead and give that other Labetalol.
All right. Okay. 10 more Labetalol now.
You see it?
Yep.
So you can hear the audio too. So that's just a little thing to do to make it good. Okay, I'm just going to bump you up there. Okay, so that's essentially how you present. And you know, we have kids from Africa presenting on their smartphone. You can present from a smartphone.
Nice.
Yeah, well, the thing that's nice about it is that even though they're in a low bandwidth area, the PowerPoint itself is great. It looks just as good as yours, PowerPoint, because the PowerPoint doesn't need a lot of bandwidth to show the slides and the text and stuff. But you don't have to worry. We don't have to worry about that in America. Bandwidth is pretty good usually.
Yeah, yeah.
So
that's great because, like I said, we cover multiple hospitals. So this way we can just give the presentation one time and have them all log in.
Yeah, you could tie your whole community together.
Yep.
Very easily, and you could tell them, hey, every Thursday at 7 o'clock we're going to have a meeting, or every second Thursday, whatever.
Yep. Yep. Yep.
So we're here to promote neurosurgery education. I know I'm looking at the end of the tunnel. I'm going to make money, but I mean, it's fun now. I like doing it, and I'm meeting some great people all over the world, and I know it's good for education. And you know, what doctor does not like education, you know?
No, this is great, and I really commend you for that.
Yeah, well, yeah, you'll see, and maybe you'll really like it and really use it a lot. Yeah, and
I have another partner who does a lot of lectures. I'm going to talk to him about this.
Yeah, I'll be glad to show him anytime if he wants to see it, or if he wants to give presentations in neurosurgery. Yeah, he's welcome to.
Yep.
So, okay, Mazen, good to hear from you and see you. And just send me an email, let me know. And I'm always ready to do a video chat to talk about something.
Absolutely. Thank you so much, John.
Okay, have a good day. I'll send you we edit this. We have an editor now in Brazil that will edit this video and send it. So it's a little step.
Okay.
Okay.
You have my email.
Yep.
Yep.
Oh, wait, do I have your email? I don't
When
know.
I logged in, I had to type it in. It's,
Can you
my
just
last-
type it in again, please?
where do you want me to type it in?
Yeah, type in, it says chat. The bottom of the screen, it says chat.
Yes.
And then go to the chat box and just type it in there. You probably get emails now, right? From me. Do you get emails from me announcing events and stuff?
Not yet.
Okay, I'll put you on the email list. That means every event we have, you get an email.
Yep.
That you can come in if you want.
Yeah, there's my email.
Okay, there I go. Yep, Abuawa. Okay.
At hotmail.com.
Okay, very good. Okay, very good. Okay, we'll be talking to you soon.
Very good. Thanks, John.
Bye-bye.
Bye.